Hello, my name is Dean LaBarba, and our research group is from Kaiser Permanente in Los Angeles, California. I will be sharing with you our abstract entitled Early Features of Pancreatic Ductal Adenocarcinoma are frequently present but underreported on cross-sectional imaging. Pancreatic ductal adenocarcinoma, or PDAC, has a high morbidity and mortality and is the third leading cause of cancer-related deaths in the United States. At the time of presentation, over 50% of patients will have locally advanced or distant metastatic disease, with only 15 to 20% that have resectable disease. Previous studies have demonstrated that patients with incidentally discovered PDAC, especially those with sub-centimeter lesions, were documented at having improved survival rates because they have a higher likelihood of possible curative resection. So if we can detect PDAC earlier, maybe we can identify more resectable cancer and save more lives. We hypothesized that the frequency of imaging features suggestive of pancreatic cancer in radiology reports is consistent with radiology images. Our first objective was to evaluate for the presence of imaging features suggestive of pancreatic cancer on pre-diagnostic imaging, CT and MRI, both with direct image review by an expert radiologist and with extraction of findings from clinical radiology reports. And our second objective was to determine how likely imaging features suggestive of pancreatic cancer are included in clinical radiology reports when compared to expert review. We identified patients that were at least 50 years or older diagnosed with PDAC between the years of 2006 and 2017 that also had abdominal imaging, CT and or MRI done in a time frame of 3 months to 3 years prior to their diagnosis of PDAC. From this, we identified a sample of 50 patients with a total of 107 images. Our study included 7 distinct imaging features which were chosen a priori, as they are known imaging features that can be seen in early PDAC or premalignant lesions and are most likely to be included in radiology reports by a general radiologist. The written radiology reports were then manually reviewed to see if these features were present in the reports. Then an expert radiologist, blinded to the clinical reports, reviewed the pre-diagnostic CT and MRI images for the presence or absence of the 7 features, the reference standard. The accuracy of the clinically reported features was evaluated against the reference standard, the radiologist image review. From this, we were able to calculate the presence of each feature reported as percent frequency from both reviews and the accuracy measures, including sensitivity, specificity, positive predictive value, and the negative predictive value. In the left column are each of the 7 features that we investigated. The second column shows the presence of each feature in the radiology reports. The third column demonstrates the presence of each feature by direct image review. This is our reference standard. You can see the discrepancy between the image reports versus our reference standard image review. For nearly all the features, the presence was much higher under image review. We were able to find that many abnormalities of the pancreas on CT or MRI are frequently present but underreported on radiology reports. In many instances, these abnormalities were not included in the clinical radiology reports. So why are features not described? Some findings are subtle and may be missed by less experienced radiologists. And this matters because extraction of data from clinical radiology reports without expert review may significantly underestimate the prevalence of imaging features. Mining of radiology reports by natural language processing may prove to be inaccurate in studies looking at the presence of abnormal imaging findings on pre-diagnostic studies. Possibly synoptic or standardized reporting may help with consistent reporting to identify early features of PDAC. Thank you for listening to our presentation. Please leave your questions below.